Greetings and welcome to this video on antipsychotics for a general physician. In this series of clinical pharmacology, we'll discuss about haloperidol, risperidone, olanzapine, and quetiapine, which are commonly used in the medical words. This is completely for educational purposes. Let's get started. So what we discuss now in this video is haloperidol, risperidone, olanzapine, and quetiapine, which is commonly used in the wards. The goal is to focus on what the general physician prescribes for hyperacute delirium, acute agitation, and for palliative care. Long-term schizophrenia management, or that is left for the psychiatrist to be discussed. It's not being discussed in this video. So mainly haloperidol, it is the typical antipsychotic, is commonly used, available as Serenase, uh, high potency drug used for acute delirium, has quick onset of action with a lot of side effects. Risperidone is an atypical antipsychotic. It's an oral workhorse, can be given orally. Olanzapine is also an atypical antipsychotic. It has a strong sedative effect and high metabolic risk. Quetiapine is gentle and sedative, safe in Parkinson's disease, and also an atypical antipsychotic. So, how to think before prescribing? So, prescribing an antipsychotic, you must have few consideration in mind before prescribing any antipsychotic because it has a lot of side effects. So is it a reversible causes like hypoxia, sepsis, hypoglycemia, alcohol withdrawal, hepatic encephalopathy? In all these cases, if the patient is agitated or having delirium, try to fix the causes rather than giving an antipsychotic drug. So fix the cause first. Drugs are just adjunctive. So red flag signs such as Parkinson's, avoid D2 blockers, it has catastrophic rigidity, avoid Serenase or haloperidol. It can cause further worsening of Parkinson's. In case of QT prolongation, try to avoid antipsychotics. In case of hypotension, avoid IV agents. So haloperidol, it's used as an acute tool to control the acute delirium present in the ICU psychosis, ICU in ICU or in wards where the patient is suddenly starting to act psychotic and causing self-harm or harm to the staff or the attenders or the doctors. It is used in palliative care and for nausea also. So even for chronic hiccups which is not responding, it can be used as an off-label drug. So it is a typical antipsychotic which is high potency D2 blocker. It has pros are the less hypotension and sedation. So it has a lot of side effects. So it is not a good antipsychotic because it worsens Parkinson's. So most of the elderly patients have some kind of another issue regarding the use of haloperidol. So elderly may have prolonged QT or torsady history. There will be severe hypokalemia, hypomagnesemia in the past, which will be worsened by haloperidol. There can be Parkinson's or Lewy Body Dementia, which can lead to further exacerbation and cause severe extrapyramidal symptoms in the use of haloperidol. So try to avoid usage of haloperidol in elderly. So, for extrapyramidal symptoms, dystonia, Parkinson, akathisia can be exacerbated by haloperidol. Cardiac, it can cause QT prolongation, especially with high IV dose, such as 5 milligram is a very high dose. And, so there can be neuroleptic malignant syndrome, which can be rare, but it is life-threatening. So elderly delirium, we use a minimal dose, very minimal dose of 0.25 to 0.5 milligram, which is a very good dose and cause sudden response to the medication and the resolving of psychosis. In case of renal failure, it is generally safe, but monitor the sensitivity. In case of cardiac, ECG mandatory. Avoid if QTC is high. So, what dosing is 0.5 to 1 milligram per oral or IV? Repeat Q second hourly SOS. That is whenever, if necessary. Maximum, you can go up to 3 to 5 milligram per 24 hours on the ward. The goal is to calm the patient and not to comatose the patient. Taper as soon as possible. Always avoid usage in Parkinson's disease, hypoactive delirium, that is quiet and drowsy patients. As long as maintenance without psychiatric input, you can use for haloperidol. So risperidone is an oral workhorse in atypical antipsychotic with D2 and 5-HT2A antagonism. So for psychosis continuation, bipolar mania can also be used for delirium orally in case of elderly. It has a black box warning in case of elderly with dementia because of increased risk of stroke and mortality. Use only for short term with the lowest effective dose. So the dosage standards for psychosis 1 to 2 milligram oral at night. Taper target is 4 milligram per day. In case of elderly, try to start at a very lower dose of 0.25 to 0.5 mg at night. Titrate slowly. It can rarely cause hyperprolactinemia and cause calprolene and amenorrhea on prolonged usage. Extrapyramidal symptoms can be dose dependent on more than 4 milligram per day. It can also lead to orthostatic hypotension. So elderly patients already on sepsis, if you give a risperidone due to for psychosis, it can further worsen the hypotension. So olanzapine is mainly used as a sedative drug more than an antipsychotic drug. It is an atypical antipsychotic with strong H1 and M1 blockade. It is very effective and very sedating. So used in acute agitation, oral or IM, it can be also be used for mania. So when a patient is needs sleep and suddenly delirium and not able to sleep with mild delirial behavior in ICU, you can use always use olanzapine. There is a risk of weight gain, hyperglycemia, diabetes, dyslipidemia in prolonged usage, and try to avoid Olanzapine in case of uncontrolled diabetes or obese patients. That is a use case for Olanzapine. So agitation, you can use 5 to 10 milligram at night. Elderly start at 2.5 to 5 milligram. In case of IM, 5 to 10 milligram protocol driven can be used as for olanzapine. So avoid usage of concomitant benzodiazepines because of severe respiratory depression. Smokers avoid using olanzapine due to decreased clearance. Clearance is increased due to cytochrome enzyme stimulation. Hepatic failure, there is risk of encephalopathy in sedation in case of olanzapine use. Quetiapine is a gentle choice. It's an comparatively a better antipsychotic. It is a soft T2 blockade with lowest extrapyramidal side effect syndrome. The safest in Parkinson's disease and Lewy body dementia is Quetiapine. In fact, it is very sedating because of histamine blockade. The major adverse effect of this drug is the orthostatic hypotension. So, not used for patients on sepsis or low BP. There is high fall risk in elderly. Always use in caution with syncopal history. So what dosing you can start with a start dose of 20 to 12.5 to 25 milligram per oral. Repeat if necessary after 60 minutes if needed. The maintenance is 25 to 50 milligram HS if needed. So antipsychotic doses are much higher, up to 300 to 800 milligram, which is not used for acute delirium. So limitations are oral only, no IV IM formulations. There is a QT prolongation risk, moderate risk, hypoactive delirium. It can worsen their drowsiness. So it is an oral only drug. It has a mild effect on QT prolongation comparative to a better drug. So quick decision table, if the patient is having hyperactive medical delirium, haloperidol is the most preferred choice. Always use in caution in Parkinson's disease, having QTC prolongation. Try to avoid usage of haloperidol. Avoid benzodiazepine monotherapy for hyperactive medical delirium. Case of Parkinson's or Lewy body dementia, avoid haloperidol. In these cases, usage of quetiapine is always considered. There is a violent agitation in young patients. Try to use olanzapine. Avoid usage of low potency agents. In case of obese diabetes, try to avoid olanzapine because it can cause metabolic issues. Then you can always use quetiapine and risperidone. In case of prolonged QT, benzodiazepines is the safe. If you need to consider an antipsychotic drug, consider quetiapine rather than haloperidol. So when not to use, in case of unassessed coma, when there is no vital signs or glucose checked, always avoid antipsychotics. Hypoactive delirium, when the patient is quite sleepy, focus on the cause rather than giving an antipsychotic drug. In case of neuroleptic malignant syndrome history in the past, try to avoid the antipsychotic drug because it can exacerbate and can be fatal. Usage of antipsychotic as a sleeping pill is not recommended. We do not use quetiapine or olanzapine for simple insomnia in stable patient. You can always use melatonin and trazodone. So, if you have not watched the video on antidepressant drugs, you can always go and watch the video on antidepressants where we discussed about trazodone and mirtazapine and other antidepressant drugs. If you have not watched the video on sedatives, we discussed about melatonin in detail and other sedative drugs such as benzodiazepines in that video.